We will now be performing the respiratory physical examination.
Before doing a thorough physical examination, be sure to have the complete health history of the patient. Before starting, inform the mother or the guardian of the sequence of the physical examination and ask for the mother's consent. For inspection in the respiratory PE, check for alar flaring, cyanosis, chest wall deformity and chest retractions, for infants, check for head bobbing, and lastly, count for respiratory rate. For auscultation, using your stethoscope, listen from top to bottom, anterior and posterior. Listen to the lungs, compare each side symmetrically. Use the diaphragm of pediatric stethoscope to auscultate. Lower lung lobes are auscultated posteriorly. Listen to both inspiration and expiration with the normal ratio of 3:1. Do the same for the back and describe breath sounds as clear or with adventitious breath sounds. Watch out for wheezes, crackles, and rhonchi. For palpation, first check for tactile fremitus while an infant is crying or by asking a cooperative child to say 99 or tres. Feel for symmetry in the transmitted vibrations. Next, check for chest lag by using the palms of the hand and placing it in the lower back and evaluating symmetry of expansion of the space between the thumbs. For respiratory percussion, percuss the same areas as with doing tactile fremitus. Bend from the wrist to tap your child's chest so the pounding does not hurt. A loud hollow sound should be produced by trapped air between the cupped hands and the chest. A slapping sound indicates that your hand is not cupped enough. Percuss only over the rib cage, and it should sound resonant. In infants, the chest may be hyperresonant throughout. Dullness may indicate consolidation or presence of mass.
We will now be doing the cardiovascular physical examination.
For cardiovascular inspection, check for cyanosis. Next, check for the clubbing of fingers. You look for the diamond-shaped window between your index fingers. Next, check for the precordial bulge. Check for any visible motion. And for palpation, feel for position of the point of maximal impulse, using palms or the base of the fingers. Next, palpate for thrills on the anterior chest wall and on the suprasternal notch, using palm or the base of fingers. Next, feel for vibration known as heaves. A rolling heave at the left sternal border suggests an increase in right ventricular work, while the same kind of motion closer to the apex suggests the same thing for the left ventricle. Next, feel for pulses on wrists, radial pulse and dorsum of the feet, or dorsalis pedis, or femoral and brachial pulse in a neonate. Next, check for capillary refill time. Should be reported as a brisk, prolonged, greater than 1.5 seconds, and very prolonged if it is greater than 3 seconds. For auscultation, listen for heart sounds using the diaphragm of your stethoscope. Auscultate in the second right intercostal space or the aortic region, the second left intercostal space or the pulmonic region, the third left intercostal space or the Erb's point, the fourth left intercostal space or the bicuspid region, the fourth right intercostal space or the tricuspid region, and the fifth left intercostal space or the mitral region. Next, listen for heart murmurs using the bell of your stethoscope in the said regions. Also listen for the murmur in the axilla and back. Listen also for friction rubs. And lastly, also count the heart rate of the patient.
And now we're going to perform an abdominal physical exam.
For abdominal physical examination, be sure to drape area below the waist of an older child, appropriately for kids, or make sure an infant is safely placed on the center of the bed and will not fall easily. For inspection, check for abdominal distension, localized swelling, and discolorations. For auscultation, be sure to warm the diaphragm of your stethoscope. Auscultate the 4 quadrants and count for vowel sounds. Normal vowel sounds are at least 4 to 5 per minute. For palpation of the abdomen, palpate the 4 quadrants to assess tenderness. Ask the child to point where it hurts and palpate this area last. Relax the tense abdomen. Next, do the light palpation in all 4 quadrants. After which, do the deep palpation in all 4 quadrants. Next, palpate for the liver and check for hepatomegaly. Palpate from the right lower quadrant upwards using the scooping method. Next, palpate for the spleen and check for splenomegaly. To measure the total height of the liver, percuss the right lower quadrant and move upwards towards the costal margin. Mark the point at which dullness is percussed. Next, start to percuss for the spleen. To test for fluid wave, with the patient supine, another observer places the hand vertically on midline of the abdominal wall. The examiner places the palm of the hand on one side and taps with the finger on the opposite flank. Next, percuss the abdomen lightly in all 4 quadrants to assess the distribution of tympany and dullness. Test for shifting dullness. With the patient supine, percuss over the area of dullness and ask the patient to roll over and lie on the opposite side of the percussed dullness. If the dullness is not percussed, fluid may shift to the side where the patient is lying.